Hi everyone, so for this week's What Could It Be Now, I am presenting a 33-year-old female with vesicular lesions. So upon presenting this patient to my preceptor, some of the things that I want to be thinking about for a differential diagnosis would be herpes simplex virus. It's the first one that comes to mind. Something else it could be would be a sunburn. It could be contact dermatitis. This could also be friction blisters. Other things that would be important to think about are drug reactions. Specifically, one that comes to mind is Stevens-Johnson syndrome. Another disease it could be is porphyria, cutaneous tarda, and this also could be an autoimmune, pemphigus vulgaris. I have decided to present the difference between herpes simplex virus and porphyria cutaneous tarda. I'm going to prove to my preceptor that this patient has herpes simplex virus and not porphyria. So starting off, I have this Venn diagram so that I can compare and contrast all the symptoms going on here and all of the different characteristics. So first of all, the thing that these both share is vesicular lesions. So I'm going to put that right in here. And I'm going to start off with herpes simplex virus risk factors. So males and females, oh my goodness, males and females are equally susceptible to this virus. And it's usually seen between people between 0 and 49 years of age. It is transmitted through intimacy, the biggest mode of transmission is actually through family. It's also transmitted through delivery from mom to baby, contact sports, and it can be transmitted at daycares through saliva. Specifically the lesions fluid within the saliva, because often these are, in herpes simplex virus type 1, it's an oral lesion. So in porphyria cutaneous tarda, the risk factors are also equal amongst male and female. We see this in mid to late adulthood. This is seen in patients with a uroporphyrinogen decarboxylase mutation. So we're gonna just, it's also abbreviated as UROD mutation. This is also seen in patients with hereditary hemochromatosis. And this is exacerbated in patients that are using alcohol, smoking, anyone who has Hep C, or using exogenous estrogen. Okay. Other things to note are the lesion qualities. So specifically location, size, and fluid inside the lesions. For HSV, we're going to see these mostly in mucous membranes. And it can also be seen on skin if the skin is broken and comes in contact with the vesicles fluid. It's usually, this is considered a true vesicle because it's less than or equal to 1 centimeter in size, and the fluid within is usually clear or straw colored. So we can kind of prove that she fits this. She's also fitting some of these risk factors. We don't know specifically any of this, but for this sake we can say that she has oral lesions. which is linking back to these qualities. Talking about Porphyria cutanea tarda's lesion qualities, these are seen on the hands, forearms, face, neck, ears, and feet. These lesions are now greater than 1 centimeter, and this is no longer considered a true vesicle. This is considered a bulla or bullae, but is still a fluid-filled lesion. And this fluid tends to be serous to serosanguinous. Another thing to note here is that these lesions last 7 to 18 days. And these lesions, which is the biggest thing, are photosensitive. And come on as a delayed reaction. So oftentimes, patients will go out in the sun, hours later they'll get these lesions and they won't connect the dots that it's due to the sun. So other signs and symptoms that can help us differentiate and prove that it's HSV would be fever, malaise, pharyngitis, this usually comes with increased mouth pain, local lymphadenopathy, and the onset is typically 2 to 12 days post being exposed to the fluid of one of these lesions. On the other hand, Porphyria cutanea tarda, you're going to see itching, fragility of the skin, hypo and hyper pigmentation. You're going to see pseudo scleroderma. And hirsutism can be seen in these patients. And also alopecia. And a big one is hepatic involvement. So part of the reason that I picked this is because when I was reading up on the disease, it was really noted that a lot of times porphyria is misdiagnosed because the symptoms are so generalized that a lot of physicians miss it. Specifically, what's happening here is the patient has a porphyrin enzyme that is inhibited in the hemoglobin cascade, and this causes the porphyrin enzyme to be deposited inside of the hepatocytes, causing the liver involvement. When talking about sensitivity, these patients are going to present with some mild to moderate illness, and it's going to be due to these symptoms here. They're going to present as if they have a virus, because they do. But in this case, this is going to come across a little bit more moderate to severe, because these lesions are covering a larger portion of the body. They're also a lot bigger lesions. And if there is hepatic involvement, this patient, depending on where they are in the disease process, might need to be hospitalized, not to mention they are at risk for infection because of all these open lesions. So Yeah, I think that